what I want to do is, or what Elisa has asked me is to, you will see I'll talk about a couple of topics. And also, maybe for people that haven't heard me speaking before, what I try to do is try to go towards the pathophysiology and the mechanics, because I really think that understanding the things that we're looking at is the basis for then going to imaging. So, when we talk about cardiac resynchronization therapy, well, we know it's a heart failure therapy, and we know that there's still a lot of problems in predicting them, which is a combination of a lack of knowledge, a lack of technology, but also a way that we look at heart failure, or especially that our colleagues in electrophysiology or heart failure are looking at it as compared to imaging people. And the main thing, I think, but that is generally in heart failure, and it's very specifically also in CRT, is that we have to realize that heart failure is a syndrome. I mean, it's not a diagnostic disease, it's not an etiology, it's a syndrome, and we really need to see whether there's different etiologies that might be, or where we might have to approach it very, very differently. And when we look at a therapy, and like even when we look now at the guidelines, in the end what the guidelines say is that we have a heart failure person which is symptomatic, where there's probably some systolic dysfunction and there's something wrong with the electrical activation, because that's what the criteria are saying. But it's very non-specific. I mean, we know ejection fraction might not be the best way to look at systolic function. Definitely QRS duration is not the best way to look at any electrical problems. And then, of course, symptoms. I mean, symptoms are, of course, important for the patients, but it's also, again, non-specific. So what we really need to try to understand is, like, if we're going to use electrical therapy, is there an electrical substrate that can respond to an electrical therapy? Because otherwise electrical therapy will never work. So we need to find ways to look at this. And then, of course, the next thing is also, can we deliver this therapy? Yeah? We know that there's a lot of problems with accessing, for example, through the coronary vein, all this kind of things. So this is a secondary problem that we will have there. And so the idea is to try to identify the potential responders. And as you know, and still partially going on in the literature, is people have been proposing different parameters in order to do that. But we know by now that a single measurement of the synchrony will not work. Well, actually, a single measurement in cardiology will not work. I mean, some people think that E to E prime, for example, is a magical parameter for diastolic dysfunction. Well, sorry, it's not. It's like there's a large group of people where this doesn't work at all. So, in general, a single parameter is not what we should look for. What we try to do is we should really interpret things. And that's why I want to take one step back. I want to say, like, okay, we go to electrical therapy. Which are the potential substrate, the potential etiologies that might respond to this? Well, the most obviously is obviously intraventricular desynchrony. So this is what mostly we look at. But it's not the only one, because atrioventricular desynchrony can also be paced, or interatrial desynchrony, that can also be a problem, and even interventricular desynchrony is something you can look at. And you can already imagine that these four are very, very distinct substrates, and there's not going to be one technique or one way that we can look at it. And even when you look at intraventricular desynchrony, it's like the typical one is the LBBB patient. So we say, like, okay, CRT is for an intraventricular LBBB patient. That's the typical one. It's potentially the biggest group. So we need to understand this. But this is not the only way that we can have intraventricular desynchrony. For example, we know that pacing-induced desynchrony can also lead to heart failure in some people. There might be early activation segments. WPW, for example, can also have some problems with desynchrony. Or even non-compaction cardiomyopathy. We won't have a lot of time to go in detail, but non-compaction cardiomyopathy actually has some intrinsic desynchrony because of the tissue structure. So let's go to try to understand this intraventricular desynchrony. And so for that, what we need to do is what's going on with the myocardium, with the cardiac mechanics, when we, for example, have a problem with the activation. And so we really need to start with what is the normal activation, of course. And the normal activation, as we know, goes through, means sinus node, AV node, we know that. You go into the bundle, and then you come into the Purkinje system. And we have a Purkinje system, which is actually endocardially placed, in order to have an electrical activation of the endocardium as fast and quickly as possible. For example, even the false tendons, the false tendons that we have in the ventricle are really important because they are actually electrical shortcuts. All of this, the Purkinje system, together with the false tendons, make that the activation of the endocardium is very rapidly, and then that means that the myocardium can start to contract everywhere at the same time. And what you need to look at is, for example, a segment. So in a normal activation or normal conduction system, what we have is that still the first activation would be around the kind of apical part, mid part of the septum. That's where you come the quickest, or where you have the first kind of Purkinje system getting into. So say that this is my mid-septal segment, for example. So it gets electrically activated, it starts to develop force, and it wants to contract. But keep in mind, this is of course connected to the segment next to it. So that means that if we have this segment is starting to contract, is being activated, what it will try to do is it will try to, of course, stretch the segment next to it. Because it's connected, it will interact. A force from this myocardium will be felt by the segment next to it, and it will try to stretch. Now, if this segment is activated at the same time, it will develop the same amount of force, because force development is very homogeneous in the ventricle. So that means that this one starts to pull back in some ways, and the result is that all the segments work together, and you will see that the base is actually being dragged towards the apex. That's normal function. Everything at the same time, they work together, they don't work against each other, they work together in order to do the contraction. Now, when we have an interruption of the left bundle branch, so what we now get is that the activation will not be through the Purkinje system anymore, but the activation has to go from cell to cell through the myocardium. That's about 5 times slower than normal. So that means now, if I have one segment here that is being activated, and now actually we have the activation again a bit more basally in the septum mostly, because now the activation from the left ventricle mostly comes from the right. The right is activated, and the activation from the right travels through the septum, and it's this kind of basal mid-septum which is first activated. And now this segment is starting to contract, but if we now look at a more apical segment which is connected to it, it's not yet activated. So that means that now this segment starts to contract. Since this one is not contracting back, what actually happens is it can actually start to stretch this segment. And it's actually easier to stretch the connected segment than build up the pressure, because we know pressure buildup in the ventricle needs a lot of force. We need the whole of the ventricle in order to do that, so it's much easier to stretch a surrounding segment. Now, of course, electricity still keeps on traveling, so a little bit later on, this segment, of course, also gets activated. Now, this one, what was stretched before, is starting to contract and might stretch back. So that's the principle, and if we look at this in the setting of a ventricle, so what you will see is that obviously at the onset of the QRS, that's where activation is starting of the ventricle. We will see that the septum is starting to be activated, is starting to contract, is moving inward, and is actually stretching the apex and the lateral wall. Now, a little bit later, all still within the QRS complex, because everything happens during the activation, and the fact that the activations take very, very long. What happens now is that a little bit later, actually the lateral wall is starting to be activated and is now contracting, and can actually now start to stretch the septum and pushes it out. And then later on, during the ejection period, it's mainly the lateral wall which is doing all the work. This is doing the contraction, the pressure buildup, the ejection, and then the whole ejection phase is happening. Now, if we then look at the filling phase, so the first part, during the isovolumic relaxation, what needs to happen is, of course, in this case, the septum was fully stretched. The first thing that needs to happen is, of course, the septum needs to unstretch, and only after the septum is unstretched, we see that the ventricle relaxes. So we have a very long isovolumic relaxation time there also, because we first have a kind of bit like a D-interaction of segments before the actual filling can really start and the pressure was going down. And here you nicely see that in the setting of the ventricle. Well, actually here you see a slowed down version. So when you really look at it, what you see is you see this rapid inward motion of the septum, rapid outward motion of the septum, and then the rest of the filling. This rapid inward and outward motion is within the QRS complex. It's predominantly within the isovolumic contraction period, but it's always within the QRS complex. That's very, very important, because sometimes you might have interaction between left and right ventricle, but that is always longer than the QRS itself. And so actually an interesting way to look at it is we have been calling this the septal flash. Some people call it septal beaking or typical pattern or whatever. There's a lot of ways to do it, but what you really see, and M-mode is actually a really nice way to do it, whether you take real M-mode in the peristernal view or you take anatomical M-mode, what you see is that the septal wall at the beginning of the QRS complex starts to move inwards, then starts to move outwards at the moment that the lateral wall is actually starting to move inward. And what we see is that actually the septum is not contributing, mostly during the ejection is actually moving outwards, and it's the lateral wall which is doing the ejection. Actually, when we look at some of the early parameters, where Pizzalis, for example, published this, that there was this septal posterior wall motion delay, actually the most interesting part is that in the first publications, they actually mainly used patients with this septal flash, where you really nicely saw this, and then this is a very good parameter to measure. In the paper that following said that this parameter is not working, well, actually they used predominantly patients that did not have this. And I'll show you later that actually there are, of course, patients that do not have it. It's only when there's pure left bundle branch block that causes this abnormal activation that you see this mechanical event. And so it's by coincidence in some ways that you see a parameter being kind of discontinued because of a wrong interpretation in some way. Yeah? So, and I think that's really important to look at. Now, what is also important, and it's partially shown here in this figure, is that this is actually a gradual process, because this depends on when the lateral wall is starting to contract with regards to when the septum contracts. So if you have a really full left bundle branch block, the septum can fully move inwards before the lateral wall is starting to move outwards, and you really have this pattern where you have the septal flash and then the septum moving outwards. However, if the activation is a little bit faster, maybe you have a little bit of Purkinje left, what happens is that the septum will start to move, but almost immediately the lateral wall is starting to move, and then you will have a pattern which would be like a small septal flash, and then you would still have septal inward motion. So it's really a gradient of depending on the patient. I'll show you some examples there later. Now, when you then look, for example, at the nuclear literature, and then what I've been saying there, for example, what you see is that you really see perfusion and metabolism defects in the septum in this kind of dilated cardiomyopathies with left bundle branch block. Of course, initially, people would say, okay, there's a problem with the coronaries. But when you start thinking about it, so when the septum is starting to contract, and is contracting by just kind of stretching the lateral wall and not building up pressure, actually the septum is not using a lot of energy. So there's virtually no metabolism because there's not a lot of energy consumption. So you have that the metabolism and the flow is kind of downgraded, not because there's a problem in flow or metabolism, but because there's no need whatsoever, because it's an unloaded contraction, so there is no energy consumption. And you will see that with CRT, that normalizes, so you have to really be careful. It's like when you interpret these nuclear images, there is a problem of perfusion because the perfusion can't get there, or there is just a kind of degrading of the perfusion because it's not needed at all. And this is really important to understand these differences. Now, when we now apply CRT, what we're going to try is to make sure that the lateral wall is electrically activated almost at the same time as the septum. So what you're now going to do is you're going to try again to avoid that the septum is being able to contract against a non-contracting lateral wall. So what you want to do is you have this one contract so that again they develop force at the same time and work together. And as you can see here, so here is a patient where there's a clear the septal flash at the moment. You see septal flash. At this moment, the CRT is being put on, and you see there's no septal flash whatsoever. So in pure left bundle branch block, cardiac resynchronization therapy is a super acute event. With the first pacing beat, you see that this disappears, and immediately you will see that the patient gets better, and even after a couple of heartbeats, you start to see that the volume goes down. So these are like the super responders, as we say, because they mostly do not have underlying problems with the tissue. It's really just this mechanical event, and so you can very easily see them. What is also important to understand is that, of course, this is a mechanical event that makes that the ejection is very, very inefficient, but actually it has a lot of consequences also, because what I told you before is the isovolumic contraction period is very long because we have this whole interaction before pressure is being built up. And the isovolumic relaxation period is very long because, again, we have this interaction, which means that the effective ejection period and the effective filling period are bad. So that means that the total stroke volume will be much, much, much reduced, both because of the systolic and the diastolic part. But one of the things that you also see is that because of this long isovolumic contraction period, where the septum does contract but does not build up the pressure, what happens is that the mitral valve is not being closed properly. Because when you look at mitral valve closing, the mechanics of mitral valve closing is twofold. One is atrial relaxation, dragging the mitral valve towards the atrium, and then you need immediately ventricular contraction, closing the mitral valve. So the ventricular pressure buildup is closing the mitral valve. If the ventricular pressure buildup is not properly happening, the mitral valve does not close. And so what you will see is that during this isotonic contraction period, what you will see is that the mitral valve is still relatively wide open, and you start to see diastolic or presystolic mitral regurgitation. And when you look at the mitral regurgitation, what you see is it looks like this velocity is not high. It looks like being at high velocities, but keep in mind, this is at a valve which is not closed. So the regurgitant orifice at this period is much, much, much larger than later on. So that means that you have a systolic problem, you have a timing problem, and you generate extra volume overload to this ventricle, which of course makes that they can fail very rapidly. And then when you start pacing, they will come back also very, very quickly because you're actually solving all these problems at the same time. So again, when you evaluate these patients, looking at diastolic mitral regurgitation is something very, very important because that is part of the mechanism that can be related to this. And you see after pacing, obviously, in these patients which are dilated, you mostly still have some functional mitral regurgitation, especially in the beginning. But what you see is that the diastolic mitral regurgitation has gone, which means that the volume overload has dramatically reduced. Something we don't have time to go into detail, but actually because this interaction and this stretching of tissue, what is happening is that actually the conduction is also being delayed and being altered. And you see that you will have these notched QRS complexes. And so when you have a septal flash, you will mostly or almost always also have a notched QRS complex. So notching of the QRS is actually a result of mechanoelectrical interaction of what's going on there. So that's why this notching has also been looked at as something which is interesting. It's not specific. If you have notching, then you not always have a septal flash, but when you would have a big septal flash, I think you will always have septal notching. Now the other thing is, of course, how does this relate with infarctions? Because there's a lot of things being published about infarctions, but what you will see is that, of course, infarctions can change the dynamics. If you have a septal infarction, but you still have some tissue left there, you will still have a septal flash. It might be less, but you will still have it. Although when you have a lateral infarction, especially if it becomes larger, since the lateral wall contraction is the thing that stops the septum from contracting and stretches the septum, when you have a lateral infarction, you will not see the septal flash anymore. And then the septum has to contribute, but in a very inefficient way. So again, thinking about the mechanics, when what is contracting and which contraction has changed, will tell you something about these patterns that you can really see there. Now, that is for pure left bundle branch block. And as we said before, pacing, right ventricular pacing, traditional right ventricular pacing, can also induce heart failure. And it's actually a very similar mechanism, because what you do with a pacemaker is you will early activate a segment that will start to contract. And here you see three different patients. Here is a patient with virtually no septal flash, but you still see there's a very small notch. And actually in every single paced patient, because pacing is never physiologically, you will always see this very, very small, tiny kind of septal flash where your pacemaker will be. But you see that even although there is this one, you see there's normal septum inward motion, there's normal posterior inward motion, so this patient will never get into heart failure. However, when you start looking at the spectrum, you start to see that there's patients with bigger and bigger. You see here, there's within the QRS complex, very important. Also, the QRS complex looks widened. You see there is this enormous septal flash, then outward motion of the septum, no inward motion of the septum. So the very typical LBBB pattern, purely induced by a pacemaker. And so this patient is unlucky to have this kind of pattern. And there's a very high chance that this one will get into heart failure and you need to upgrade to CRT, or probably the lead positioning from the beginning where you put the lead in the right ventricle probably would have changed something. And that's where, for example, his bundle pacing or something like that will help, because then you much quicker get into the position, into the conduction system. So probably here the pacemaker is very far from a conduction system, probably here it's very close to a conduction system, and there you see the spectrum. And you see that actually this excursion of the septal flash actually correlates with ejection fraction in these patients. So this is another thing. If you have a pacing-induced problem, look at this and you might see that that's going on. As I said before, we don't have a lot of time for going into non-compaction, but actually many non-compactions also show a small septal flash because of the fact actually that the Purkinje system is of course subendocardially, and that means that you have to travel through all your trabeculations in the non-compacted cardiomyopathy before you activate the full myocardium. So again, you have some conduction delay predominantly then in the lateral apex where you have most of the trabeculations. And what seems to be the case is that if you have an end-stage non-compaction that clearly shows the septal flash, CRT might help to delay a transplant. And there's a couple of studies that are actually showing that that could be the case. But always look at the mechanics. If you see that that's available, then that's important. This is about the traditional intraventricular desynchrony. I think if there's an intraventricular desynchrony, there will always be an early activated segment if it's going to become clinically important. So you have to look at that. Now, as I said before, you might have different desynchronies. So atrioventricular desynchrony is important. We're not going to go very much in detail, but you all know these patients that have like a clear kind of fused ENA wave with a long PR interval, very often diastolic mitral regurgitation, because actually the PR interval is just too long. The atrium has contracted and is already relaxing before the ventricle is contracting. And this might be congenital, it might be induced with some problems. And what you will see is that actually if you pace them and you shorten the AV interval, you can actually get them out of this. This is really a filling problem. The question is, do you need a CRT here? Because with a traditional pacemaker you could, but what we see very often is that you would need a CRT because these are patients that are often kind of dilated and things like that. But the main thing is that obviously you do not use any kind of motion or deformation or B mode. Here, the Doppler of the mitral valve is of course the most important. Very briefly, interatrial delay. What you will see there, especially patients that have very dilated atria, what you will see is that actually the activation of the left atrium is much later than the right atrium. And I think this is something which is really interesting. And here you see, for example, a HFpEF patient where you clearly see that when we look at mitral versus tricuspid, there's a very big delay. And what you also see here is that actually the A wave filling in the left side is interrupted by the ventricular contraction. So if that patient is slightly restrictive, doesn't fill properly in the beginning, relies on atrial contraction for filling, and then you have an interatrial delay, making that the ventricle closes the mitral valve too early, then you will see that there's a potential problem. People are playing a little bit and trying to pace this, but this is still kind of a very gray area whether this would work. Lastly, rarely you see interventricular interaction, and it's predominantly, for example, when you have like a large septal infarct and you see this patient where the septum is being pushed in and out because of the right ventricle. Of course, the pressure builds up earlier than the left, since the left has this large infarct. With pacing, what you can do is you can pace the left ventricle a little bit earlier, so you mobilize the septum, and what we see is that we improve the filling. Obviously, pacing here is palliative because you're never going to get rid of this large kind of septal infarct. You might improve the symptoms of the patients a little bit. You will never improve this ventricle overall because, of course, there is already a large scar. And so when you then look at CRT, what I think, and that's based on what I've been saying, what you need to do is you need to go etiology based. So you need to say, what is my potentially pacing etiology? Is this an intraventricular desynchrony? Mostly you see that with a septal flash. If not, is there a filling problem? Is there an atrioventricular delay? Then maybe you can do something also. If not, maybe there's an interventricular, although they're very rare. And if none of these are present, sorry, this patient is not responding. And there are a couple of studies that are actually showing this. So the main thing is also, is like you see in the literature, there's a lot about, okay, infarcts, right ventricular function, all of these determine also outcome or response to CRT. This is true, but this is secondary. Because the first thing is there an etiology that is electrically paceable? If there is one, if you see a septal flash, for example, then the second question is, how much do you think this patient will respond? If there's a lot of scar, there will be less response. If there's pulmonary hypertension and bad right ventricular function, probably this patient will respond much less. Is there an underlying tissue problem? probably they will respond less. But this has nothing to do whether they will respond, but more how much they will respond. And then, of course, lastly, is there a problem, a technical problem in placing it? Then, of course, there might be a problem too. So what I think is that imaging, and specifically echo, although you could use MR, but the most important that these are very fast events, so you need echo, B mode echo, M mode echo, Doppler echo, these are the most important. You could do it with strain or a little bit with tissue Doppler, but I still think just B mode, M mode, Doppler, that are the ones that you have to use. Use these to detect the underlying etiology. Is this a paceable etiology? Look at which are the determinants or co-determinants in some ways for potential response and improvement of these ventricles, and based on that make your decision. There's not going to be one magical parameter that can measure this. You really have to integrate this in the knowledge, in the etiology and physiological knowledge that you have. Thank you very much.